Well, greetings, everyone. Thank you for joining our Orbis webinar on unilateral optic disc swelling. And different because instead of one speaker, we have four participants. Myself, Karl Golnik, who I am a neuro-ophthalmologist and professor at the Barrow Neurological Institute in Phoenix, Arizona.
Nice to meet everyone. My name is Dr. Jay Patel. I'm an assistant professor, also neuro-ophthalmologist at the Barrow Neurological Institute in Phoenix, Arizona.
Hello, everybody. I'm Fumi Ogun. I'm a professor of ophthalmology from the College of Medicine, University of Ibadan, Nigeria. I practice general ophthalmology and neuro-ophthalmology.
Hi, everybody. I'm Mario Perez. I'm a neuro-ophthalmology clinical advocate in Bogota, Colombia.
So our objectives for this webinar are several. When we're done, you should be able to describe the approach to the patient with unilateral optic disc swelling. You should be able to list the differential diagnosis, and you should be able to list signs and symptoms that help differentiate the various potential etiologies of the disc swelling. And here's the plan. So I'm going to present a case fairly briefly, just in a moment, and then I'll ask if there are further questions from the panelists to try to sort out what could be going on. Then the panelists will provide each of their individual differential diagnosis. We'll talk then about the diagnostic, or I'll ask about the diagnostic approach, what sort of tests might be ordered to help sort these things out. And then there will be three short talks about the most common entities that we think could result in this patient presentation. And then finally, conclusions and questions. So clearly there's a question and answer option for all of the participants, and you can put questions in there anytime you want. I don't think we're going to get to them until towards the end, but feel free to put in questions or write them down or whatever, and we will try to answer as many as we can, time permitting. The case. So here we go. So this is a 48-year-old woman. She's complaining of painless, blurry vision in the left eye for the last 2 days. Her past ocular history is only remarkable for mild myopia, her past medical history for hypertension, her family history for hypertension and a stroke in her father. Social history, she says that she has 1 to 2 alcoholic drinks per week, but does not use tobacco or any illicit drugs. Her exam, she's 20/20 or 6/6 in the right eye, but 20/80 or 6/24 in the left eye, the eye in question. She sees 11 of 11 of the Ishihara colored plates in the right eye, 4 of 11 in the left. Pupils are moderately reactive, but there is a 2+ left relative afferent pupillary defect. Visual fields are normal on the right, but sort of just generally depressed. There is not really any particular pattern of the visual field, but it's clearly abnormal. Her motility exam, external exam, slit-lamp exam are all normal, and her fundus looks like this on the left. On the right, she has a normal fundus, normal disc. And so I'll let you look at that and the participants look at that. The panelists have seen this case up to this point in the past, so they've had a chance to take a look at it. So this is the fundus appearance. So I think I'm going to leave that photo up while I ask the panelists about other questions or things they may want to know about the case. And I'm going to ask the panelists to just give me one question at a time, because I don't want one panelist to answer all the questions and then not give an opportunity for the other panelists. So why don't we start, let's see, I've got my photos in a row here. Funmi, is there a question that you would like to ask about this patient that I haven't already given answers to?
Yes, please. I'd like to ask if there's headache or jaw pain.
So there is no headache or jaw pain in this patient. She says painless, and she denies any issues with chewing at this time.
Okay.
Jay?
Did she notice these symptoms upon awakening?
She isn't entirely sure. She realized 2 days ago, sometime during the day. So it wasn't something that was a sudden, I woke up and I can't, but somewhere during the day, something doesn't seem right. And then she started covering each eye and said, oh, clearly it's my left eye. Marianne?
I would like to know the cup to disc ratio of the contralateral eye.
Aha, okay, so I did say the other fundus was normal. The cup to disc ratio was 0.1. Funmi?
Yes. I'd like to ask if she's had any similar event like this in the past.
She has not. This is, she denies any other visual issues other than the glasses and no episodes of visual loss. Jay?
What time does she take her blood pressure medications typically?
She takes one in the morning and one in the evening before bed. Mario?
Any family members with visual loss?
There's no family history of anything like this. Several of her family members wear glasses, but as far as she knows, none of her family members have had some sort of significant sudden change in vision.
Do I go ahead?
Yeah, sorry. Go ahead.
I know that her blood pressure is said to be controlled, but I'd like to know if there has been a recent change to her blood pressure medications, or what exactly was her blood pressure if it was measured.
Yeah. So I don't have her blood pressure, honestly, but she says that she thinks it's under control. She does not check it at home. I know these days, at least in the US, a lot of patients have a home blood pressure monitoring thing. She doesn't check it at home, and it hasn't really been checked for a good 8 months at this point. So of course, we should have checked it in the clinic. Now, I can tell you in my current practice, everybody gets their blood pressure checked by my technician before we see them, but this is not a patient from my current practice. This is an older practice where we didn't do that routinely. Jay?
Any subtle proptosis on exam or anything like that?
No, so that we didn't think there was any proptosis or yeah, any proptosis or any other external findings. Mario?
And is systemic signs like fever, rash?
So no, she denies any sort of fever. She has not had any rashes. Good questions. We'll I think for the audience who may not understand yet why we're asking those questions, the talks that come up, I think, will explain those things. I debated whether we should talk about that, but I think that'll come up when we have our 3 short talks as to why these questions. But I hope the audience is getting an appreciation for, you don't just ask the patient, what's wrong? I lost vision 2 days ago, and then start the exam. There are a lot of things you want to ask about that may be relevant, and you will see why they're relevant when things come up. So Funmi,
my last question would be, does she have any pets like cats?
She does have a cat.
Okay. And if she's been scratched or injured by it recently?
Yeah, she doesn't really remember any scratches in particular, but she does have a cat.
Okay.
Jay?
Any recent travel or any recent illness prior to this development?
So she says no. Her last illness she can remember was a viral thing, but it was like a year ago about. And that's 2 questions. So no recent illnesses. She does not have a fever. She doesn't think. She's feeling actually completely fine. I mean, except she's worried about the vision problem. But she's had no international travel. I would say no one's asked me, is she from the United States? She is from the United States. Of course, it's my patient, but that might be relevant. So she is from the US, and she lives in the Midwest in Ohio, United States, and hasn't really had any significant travel. Mario?
I would like to know if she eats raw food or unpasteurized dairy.
Was it
raw food?
Raw food.
Raw food. Yeah.
Yeah, so she denies eating any raw food. That's not super common in the Midwest in the US, but she denies eating any raw food. So I think Funmi's done. Funmi, no further questions?
The only thing I'd want to know is how the vision has changed in the last 2 days. Is it the same or
yeah,
better or getting worse?
Yeah, she doesn't really think it's changed much in the last couple of days. She thinks it's about the same. No big changes either way. Jay?
From me.
What's her body habitus?
Well, like many Midwesterners, she is somewhat overweight. She is not morbidly obese, but and I don't remember her BMI off the top of my head, but she certainly is at least 20, 30 pounds overweight. Mario.
I would like to know about her hobbies. Does she like gardening, going to to into the woods, or what does she like to do?
Yeah. Well, she lives near the woods. She lives in kind of a rural area. And she does do sort of walks with her, well, not with her dog, her cat. She does do walks in the woods, kind of on a, kind of a regular basis. Any other, there are actually a few questions on the, I think we have time. Do any of the panelists have any further questions they'd like
Does
to
she
ask?
snore when she sleeps?
Snore. She, let's see if I can remember if she snores or not. Her significant other isn't there, and she says she doesn't snore. Of course, I would say the same thing, except my wife says I snore a lot. But there's no, it's indetermined whether she snores. She doesn't think she does, but that's all I know.
Okay, thank you.
I'm gonna just jump. I think we have time. I'm just gonna take a look at the questions in the Q&A and just see. So one attendee asked, "Is there any history of cancer?" That's a good question, I think. The answer is no. There's no history of cancer. Let's see. Pain on eye movements? No. So there's no pain of any sort, just pain in general, or pain on eye movements. Let's see, is there any there's a question about medication. She's just taking the blood pressure medication. Her eye pressures are 16 in each eye, so normal eye pressures. And so there's a question about obstructive sleep apnea, which we've talked just briefly about a moment ago. So there's no history of sleep apnea. Good question. And there's we don't really know whether she snores or not. Perhaps we can talk about that. Any optic disc drusen? Well, certainly not in this eye, we didn't think. In the other eye, she didn't have any. That's a good question too. So that's not really a question. I'm going to skip over that, but let me just see. So Dr. Where did that? Dr. Sadiq, I think it was, said, question neuroretinitis. Well, there's no macular star of exudate now. Let's see, any history of phosphenes as the vision improves? So no phosphenes, we talked about the vision. Any field defect? Well, there's sort of a generalized depression of the visual field centrally. There's not really any particular pattern other than that. Thyroid's okay, no oral contraceptives. So we haven't talked about the evaluation. There was a comment about blood testing and so on. So we haven't talked about that yet. We're going to. No headaches. Okay, I think we'll move on from this question then. But thank you, participants, for all those good questions. So Mario, just briefly, and it doesn't have to be an exhaustive differential diagnosis, but so what are you thinking here at this point about what are the possibilities, maybe, I don't know, more or less from most to least likely?
Okay, I think the main differential diagnosis must be ischemic. I would like to find out if it could be inflammatory or infectious.
Okay, so that would be it. And part of this webinar for the participants is we tried to get panelists from around the world. So we have Nigeria, Latin America, US, and the question is, well, is it any different depending on where you live in the world? Is the differential diagnosis different? So it may not be, but that's one of the sort of things we are going to try to see is the differential any difference? Jay, what are your thoughts? And you can include more than the three things that we're ultimately going to talk about, but if you want.
Yeah, definitely. So yeah, I definitely agree with Dr. Perez and Mario. NA-AION is strongly considered, especially with the contralateral disc at risk. Evening blood pressure medications. MOG is something we have to consider as well with the anterior optic disc edema that we're seeing. Doesn't have to necessarily always be painful, but the colors are down, as you can see, and typically an NA-AION is proportional. So MOG is a consideration. Neuroretinitis, we don't see macular star just yet, but we know that occurs 2 to 3 weeks a little later. So that could be a possibility with her cat. Less likely, but things to consider would be syphilis always, and some compressive lesion or asymmetric papilledema. Again, these are like number 5, number 6. Could she have, this is more common in males, but a malignant optic nerve glioma with some hemorrhage that we're seeing? Could this be an optic nerve sheath meningioma? We don't see the optociliary shunt that occurs later. And lastly would be an asymmetric papilledema. So I'll put it in that order, more or less.
Yeah, and so certainly the latter part of your list are pretty rare. I mean, I've probably seen 1 or 2 malignant nerve gliomas in my career of 35 years. So that's a pretty rare thing. So we're getting from the common to the really less common things, but all things reasonable to think about. Funmi, what about you?
Yes. So with this patient, considering her age and the fact that she does have blood pressure issues, I would think first of an ischemic optic neuropathy, specifically non-arteritic, because she doesn't have features suggestive of a vasculitis and inflammation of the vessels, which could give us some headache and jaw claudication. Then my second consideration would be because of her age, I would want to make sure that this is not an optic neuritis, but she doesn't have pain with eye movement. Then another consideration would be inflammatory or infectious optic neuritis. We know that something like cat scratch disease could give a granuloma that would look a bit pale and swollen on the disc. But she doesn't have any history of injury from her cat. She does have a cat. She doesn't have any fever. Another thing that I would consider also in this patient would be, well, the list has been exhaustive, really. The last thing then would be something like syphilis. It's a possibility. I don't know if she's immunosuppressed for any reason, but there has been an increase in syphilis. That tends to give what people would call a neuroretinitis. She doesn't have a macular star, but it could start off with optic nerve swelling. Thank you.
Okay, and there are a couple of comments in the Q&A. One was, could this be MS? So I think MS would be very, very, very unlikely because of that significant degree of disc swelling. So let me just go backwards for a second. In the optic neuritis treatment trial, which was based in North America, so be careful applying those results wherever you live. But in the optic neuritis treatment, no patients who developed MS had hemorrhage or severe disc swelling. So that would be, to me, a big clue that I'm really not going to be thinking about MS. Jay mentioned MOG, which some of you may have or not have ever heard of, but we're going to cover that in his talk. So that's myelin oligodendrocyte glycoprotein antibody disease, but that will be covered. Someone else said, I think the differential would vary with infectious, maybe TB, of course, depending on where you live. And so we'll hear about infectious optic neuropathies from Dr. Perez regarding that, because that's an important point, and in part why I pointed out that she lives in the United States, in part. Someone else provided a list of NA-AION, AION, hypertensive retinopathy. Be pretty unusual for someone to have unilateral big-time disc swelling and a relative afferent pupillary defect from hypertension, which is systemic. I don't think I've ever seen that. Increased intracranial pressure, Jay mentioned. Again, although it is possible to have unilateral papilledema, there are a few things that would weigh against that. Number one, I've never seen that kind of asymmetric. I mean, this is big time disc swelling on one side and nothing on the other. I've seen, a grade or 2 difference between the eyes kind of a thing. And the history is not right. I mean, people with papilledema don't have sudden loss of central vision. That's just, so I think that's not Probably not. Central retinal vein obstruction. So central retinal vein obstruction certainly can cause significant optic disc swelling. It would be a little unusual to have it be 20/80 or 6/24 and have an APD. Usually you're going to see a lot of vascular tortuosity. There is maybe some dilation of these veins, so interesting. Let me just see if there's anything else. Acute on chronic vascular disorder, hypertension is chronic, but acute vascular arterial occlusions. Yeah, it'd be unlikely. I mean, if you had retinal arterial occlusions, you'd see, you know, whitening in the retina. Usually not the disc swelling. Let me just see if there's anything else here. Space occupying. So Jay sort of mentioned there could be a tumor. I guess it is important to say that if there is a compressive optic neuropathy, the compression has to be occurring in the orbit. If there's an intracranial tumor, a pituitary tumor, a meningioma, you do not get optic disc swelling from an intracranial compressive lesion, unless, of course, there's really high intracranial pressure, and then you have papilledema on top of it. So if there were a compressive lesion, it would be in the orbit. Of course, it would be unusual for a compressive lesion to cause her history, but we all know that, hey, maybe she was washing her face and covered one eye and suddenly noticed her vision was bad 2 days ago. Maybe weird, stranger things have happened, and we all know that there can be this sudden realization of loss of vision because one eye is covered. I'm looking at the time here, I saw a patient some years ago, a college student who was being evaluated for impotence. And so he got a prolactin level and they got an MRI and he had a big pituitary tumor. And the endocrinologist said, well, how's your vision? He said, oh, my vision's fine. And they said, well, go see Dr. Golnik anyway. And he came in and we checked his vision in the right eye, 20/20, 6/6. And then we covered his right eye and he said, oh, I can't see the chart. And he was legally blind, even though they asked him, how's your vision? And this was a college student. So you never know. And then a few other comments, neuroretinitis, disc drusen. Well, certainly it's not pseudopapilledema. Sarcoid, okay, that's would fall in the inflammatory. Certainly sarcoid could do this, good thought. Maybe depending on where you live, but sarcoid could cause this appearance. And someone asked, this was first noticed 48 hours prior to her evaluation. Okay, I'm going to move on then with the webinar, but great comments. So panelist, what diagnostic evaluation? Let me just see. I don't want one person to give all the answers. Why don't we start with Funmi? Okay, what are you going to order? Maybe just start with what your first thought. If you want to list a bunch of blood tests, that's okay, or just give me in general, or maybe you want to order something else on the exam. I don't know, but just tell me what you want. What are you going to do with this person maybe now?
So the first thing I'd like to look at is her blood pressure. Even though she thinks she's controlled, it hasn't been checked in 8 months.
Good point. Okay, so let's say I'm going to tell you that her blood pressure, although I don't know this because I can't remember, her blood pressure was normal. Jay, what next are you going to do? Because that's the first thing you can do, right? You can do that right there in the clinic, get a blood pressure.
Yes, very easy, non-invasive.
Yep.
I completely agree with Dr. Ogun as well. Because her age is 48, and we know NA-AION is typically, a condition of, patients a little bit older can, of course, be seen in 40s and 30s. However, because of this, I would get an MRI for her. I would get an MRI of brain and orbit, specifically with fat saturation, looking at the entirety of the optic nerve.
Okay. And presumably looking for enhancement of the nerve or maybe we already talked about how MS would be unlikely, but typically in this setting, you would be getting an MRI thinking about, are there periventricular plaques and so on, again, depending on where you live in the world. Okay, so imaging. Mario.
I would like to get visual field test.
Visual field. So she had I didn't show you the visual field. She already had a visual field. It's just sort of generally depressed, mostly centrally. You can ask for something else since we already covered that.
Sure. CBC, set rate, seed reactive protein. CBC.
Okay, so CBC, sed rate, C reactive protein, those were all normal.
Okay.
Funmi?
Yes, I'd also like to check, you know, her fasting blood sugar, hemoglobin A1C, lipids, fasting lipids.
Right. Good. So
microvascular.
vascular risk factors, other
Yes.
vascular, those are all normal too. Jay?
I'd also check what's called like a CDS1 panel or NMO and MOG.
Okay, so neuromyelitis optica or the aquaporin 4 antibody and the MOG, we'll hear more about that in the short talk. Those were sent, we don't know those results yet. There was something else. Mario?
I would like to get serologic test for syphilis.
Syphilis, okay,
Or
good.
PR.
So throw that in with the other blood tests that were mentioned. Would anybody want to do any other testing in the office? I guess specifically, I'm wondering, would you order an OCT?
OCT will be very good.
I think it'd be
Ultrasound of the optic nerve, looking for
Okay.
drusen, buried drusen.
Right, so you could look for buried drusen with an ultrasound or with the OCT. One of the participants asked about disc drusen. I said, well, there aren't any visible. That doesn't necessarily mean there aren't any drusen. So either OCT, which may be better these days than ultrasound, and depending how you are with the ultrasound. And the OCT, is there anything you're maybe looking for in the OCT in particular, other than drusen, or?
Also perhaps in the outer plexiform layer, which would be helpful because as we know, that would then could be evolved into a macular star later. So that would be helpful.
Okay, so fluid in the retina and could be, right, okay. So someone mentions Bartonella. Otherwise, the same stuff that we've talked about. Someone mentions a chest x-ray, which would get at the sarcoid presumably, and maybe TB, yes. No problem with ocular motilities. The MRI someone asked about the MRI results. It was normal. The MRI was normal. No nerve enhancement, interestingly. Ophthalmodynamometry. Boy, that's something I haven't thought about in a long, long time. Fluorescein angiogram. So that certainly would be reasonable, I suppose. Borrelia, so Lyme testing, thyroid function test. I don't know. I don't think I'd order a thyroid function test. The person has no external signs of thyroid eye disease. Having a compressive optic neuropathy from thyroid eye disease without extraocular motility problems or significant exophthalmos would be, I hate to say impossible, but I'm gonna anyway. And HIV, so someone mentioned, maybe depending on where you live in the world, maybe that would be a good test. There is a relative African people. Okay, all right, very good. So let's, hold on. So what we're gonna do, and I'm switching the order around from what you're seeing here a little bit, but what we're gonna do is have 3 short talks on these 3 entities, which at least probably in most parts of the world, these 3 things or entities within these 3 things would be we think are probably the most common. Certainly if I see 100 patients with unilateral optic disc swelling and loss of vision, it's probably going to be one of these 3 categories. So we thought we'd provide a little information on each of these. We're going to start actually with Dr. Ogun.
So how would I spot a case of non-atteretic anterior ischemic optic neuropathy? So quick points to note. From our case history, we're looking at a 48-year-old female, painless, blurry vision, sudden onset, 2 days. She's hypertensive. She says she's controlled, but there's a strong family history of hypertension and stroke. So these are strong risk factors. She doesn't have much else in her systemic history, but we know that she has reduction in vision, reduction in color vision, an RAPD, which shows that the optic nerve has a problem, and then she has depressed fields. So this is her fundus picture. And so I just try to highlight the little aspects of her history that stand out to me. So the fact that she's 48, she's under 50, she has a unilateral, painless vision loss of, very short duration. and she has evidence of optic nerve dysfunction. And she has a pale, as we can see here, swollen disc with some splinter hemorrhages around the disc, showing that there's a lot of congestion and a lot of impairment of the flow there. So again, something that was interesting was the fact that she has this medical history pointing to hypertension. So my question is this non-arteritic anterior ischemic optic neuropathy or not? What is non-arteritic anterior ischemic optic neuropathy? It's an impairment of the blood supply to the most anterior part of the optic nerve, which is called the optic nerve head, and that's the disc that we see on fundoscopy. And it arises from the impairment of flow of the short posterior ciliary arteries shown here. There are two sets of blood vessels that supply the optic nerve. These short posterior ciliary arteries that supply the optic nerve head, and then the pile blood vessels, which are branches from the ophthalmic artery that comes from the internal carotid. So there are two types. There's the arteritic and the non-arteritic. The arteritic is associated with inflammation of middle to large caliber blood vessels, and it's commoner in older patients. So in this patient, I'm considering more of the non-arteritic, which is my first consideration in this patient. So I have a polling question here. Which of these is not a risk factor for non-arteritic ischemic optic neuropathy? And we have 30 seconds to respond. I'd like to encourage everybody to vote. There are 5 options: the age, female sex, the use of the new drug Ozempic, hypertension, snoring, which you can get from the history. And I'm not sure if, okay, good, we have our votes here. Remember the question, which of these is not a risk factor? Not. So you have to look at questions here. So age under 50, I would say, is a risk factor. So unfortunately, about 34% of people didn't read my question right. Okay. About 19% think that Ozempic is not a risk factor. 6% say hypertension is not a risk factor. 21%. Okay, so we have a mixed bag here. Very good. So I'll close this and just go to my next slide. It's actually female sex. Okay, and what are the risk factors? So there's a very large study that looked at all the studies that has been done on non-arteritic anterior ischemic optic neuropathy. And while some people felt that, females and males have an equal proportion, a good number of the studies actually found that it's found more commonly in male patients. So male gender is actually a risk factor rather than female. It's very common actually in patients below the age of 50 compared to the other form, which is arteritic. That's commoner in patients over 50, usually in the elderly range, so 60 years, 70 years, and they can present just like this. Hypertension, hyperlipidemia, diabetes, coronary heart disease, these are all risk factors. Obstructive sleep apnea, which can present with a history of snoring. Usually the patient would not know this, but the patient's significant other might complain of this. So patient is reported to be snoring. And then there are some other risk factors, like risk factors for clotting, like deficiency of factor 5, which is a clotting factor, and new medications. So medications for weight loss and diabetes, the new injectable semaglutide, which is Ozempic, has actually been implicated, but it has no randomized controlled trials have been done, but there have been some few case reports, as well as medications like tadalafil, sildenafil, which are also used for erectile dysfunction. So again, in this patient, when you look at the age, she's 48 years. So I want to tell you, when you're looking at the patient and you're thinking about NA-AION, think age, 50-50. Is this patient above 50? Is the patient below 50? If the patient is below 50, you want to think of NA-AION, take it higher on your differential risk and look for microvascular risk factors. It's not that it cannot occur in patients over the age of 50, but that's less common and more likely to be the arderitic type, the one that's associated with vasculitis. And then the risk factors. So this patient is hypertensive. There's also a strong family history of hypertension and stroke. So NA-AION is a possibility. The patient has also all the clinical signs of optic neuropathy. So the next polling question, looking at the fundoscopy of this patient, what are the characteristic signs in a patient that might have NA or non-arteritic anterior ischemic optic neuropathy? Okay, flame-shaped hemorrhages around the disc, pallor of the optic disc, swelling of the optic disc, all this in the affected eye, sheathing of retinal blood vessels. Did you see that in this patient, or would you be looking for that? And then if you look into the other eye, would you be concerned whether you notice a small cup disc ratio? So please vote.
I mean, it looks like this should be a select any of these, doesn't it? Because it
Except
says
the following
except,
fundoscopy signs
sorry.
are characteristic of
Gotcha.
non-arteritic anterior ischemic optic neuropathy, except. So you have to select the odd man out. 4 of these things belong together. Okay, good. I was just about to sing Sesame Street. Okay, so good. We have also a mixed bag here, but very good. It seems like almost 40% of us have noticed the odd man out, sheathing of retinal blood vessels, which would point to vasculitis. So in non-arteritic anterior ischemic optic neuropathy, we will not be expected to see signs of vasculitis, which would be characterized by sheathing of blood vessels. However, yes, we do look at the disc of the other eye to look for signs of what's called the disc at risk. I don't know if you can see what I've written here. Let me just move these pictures here. So a smaller vertical cup disc ratio is it's highly correlated with non-arteritic anterior ischemic optic neuropathy. So in this study that was done by Gonzalez et al., they looked at what are the factors. Is it the size of the disc? Is it the disc diameter? Or is it the cup disc ratio? And of all these, the most significant finding there was a small vertical cup to disc ratio in the contralateral eye, in the fellow eye. So you can get information from the individual or the eye that is affected, but you can also get some helpful information in the other eye, because a very small cup to disc ratio, what we call a crowded disc, is a risk factor for ischemic optic neuropathy. You might not see it in the eye that is already presenting with the swollen pale disc, but you can see some signs in the contralateral eye. So we have other signs of non-arteritic anterior ischemic optic neuropathy, and one is what we call the relative afferent pupillary defect. I'm not sure whether all of you have seen this before, but when you do the pupil reactions, you look at the direct response and what is called the consensual response. So when you actually stimulate the good eye, it stimulates both pupils to constrict. But when you come back to the affected eye with an RAPD, that eye cannot sustain the constriction because of the impaired optic nerve function, and then the pupil begins to dilate, as you can see in the left eye of this patient. This is not the patient that presented to Dr. Golnik, but that's what an RAPD looks like. And patients can present with any kind of field defect. Commonly, the books will talk about what is called an altitudinal field defect. Many patients tend to have swelling of one segment of the optic nerve head or the other, much more than the other. So you could have a superior swelling, and that will give you an inferior altitudinal field defect, as you can see in this picture. Or if you have more of an inferior swelling, then you can have a superior depression of the field. And as in this case that Dr. Golnik mentioned, the entire field might be just depressed. And then, of course, when you look at the disc, we expect to see swelling. There would be blurring of the disc margins. There might be some little hemorrhages at the edge, flame-shaped hemorrhages, and the disc is swollen. So you look for these signs. And if you see them, of course, you don't expect to see shedding of the blood vessels as you would see in vasculitis. You don't expect to see round hemorrhages in other parts of the retina.
You got about 1 minute, okay?
1 minute. Yeah, I think this is my last slide. So the
Okay.
management would really be to screen the patient for evidence of small vessel disease, all these microvascular risk factors, and we mentioned the tests already. The other thing I mentioned about the vision, sometimes you have a patient that develops a sudden vision loss. It gets worse over a few days to a maximum within 1 to 1 week, about a few days to 1 week, and that's because sometimes the swelling increases. Some patients, after about a few weeks to a month or 2 months, the vision is either restored, it can get better, it can get worse, or it can stay the same. And that's roughly the case in about 1/3 of each of the patients. And of course, always look at the contralateral disc. And so the take-home points are sudden painless vision loss, that's unilateral, and associated with signs of optic neuropathy like poor color vision, sluggish pupil with an afferent in a patient who is less than 50 years should generate the impression of a possible non-arteritic anterior ischemic optic neuropathy. You want to examine the patient for microvascular risk factors and always look at the contralateral disc for a small cup disc ratio and exclude vasculitis by doing the SED rate, erythrocyte sedimentation rate. Is usually very high in vasculitis, and the C-reactive protein, which is also elevated, and that would exclude giant cell arteritis. Thank you very much.
I just gave a talk and reviewed the literature on the GLP-1 agonists, semaglutide in particular, and NA-AION. So far, there have been about 6 big studies, big data studies. 3 showed an increased risk, and 3 did not. And just on Monday of this week, 2 days ago, the American Academy of Ophthalmology and the North American Neuro-Ophthalmology Society came out with a statement because the European group came out with a statement saying if the person is on a GLP-1 agonist and has NA-AION, they should stop the medication. The AAO and NANOS came out and said, no, we don't agree with that. It needs to be a case-by-case basis. There needs to be a discussion with all of the care providers of that patient because sometimes these medicines are life-changing and important. They're not just used for weight loss, of course, but for diabetes too. So there is still debate. I don't think we don't really have an answer yet. I'm not a big fan of big data studies, honestly, because I know how badly I code things. I don't know. I think I just wanted to say that so that people don't start telling everyone don't use these medications. They are life-altering for some people. Okay, so that's certainly one of the possibilities. NA-AION, we heard about it. Let's hear about optic neuritis from Dr. Patel.
Yes, my talk is on optic neuritis. I do not have any disclosures. And briefly, our objectives would be to discuss terminology, etiology, epidemiology, classic presentation, testing, and management and prognosis. And so I have a polling question here. And so hopefully this you guys can see this. So this says, which of the following is true about optic neuritis? 1, majority of patients will present with optic disc edema. The presence of an arcuate scotoma or an altitudinal field defect excludes optic neuritis. All patients with suspected optic neuritis require a lumbar puncture, or all patients with optic neuritis ultimately require some form of long-term immunotherapy. And lastly, a patient can have optic neuritis without a detectable RAPD. Okay, excellent. So we have 32% of folks believe that majority of patients will present with optic disc edema. Very good. And looks like the majority mentioned a patient can have optic neuritis without a detectable RAPD, and the other answer choice is scattered. So that's good. So a good mix. So hopefully this will be informative. So first, to talk about terminology, optic neuritis, when we think about that, it's a term that's used to refer to inflammation of the optic nerve, as we know. And so with the swollen disc, we kind of more specifics would be a papillitis or an anterior optic neuritis. With the normal appearing optic nerve, we would refer to this as a retrobulbar optic neuritis. So you can see on the left, this is an example of a patient who basically this is a normal, fundus photograph, but this very well could be, this was a patient who had retrobulbar optic neuritis. And on the right, of course, you can see the remarkable disc swelling that we can see, of course, in typically MOG type of optic neuritis, which I'll get to. But this is briefly for the terminology. This is a pie chart adapted from Dr. Neil Miller's presentation on the various causes of optic neuritis. As you can see, it's a good schematic that shows you on the legend, you can see that idiopathic and MS make the vast majority of optic neuritis that we typically see, about 85%. A smaller subsect, about less than 10%, will be about NMO and MOG, NMO being neuromyelitis optica with aquaporin 4 antibodies, and MOG, myelin oligodendrocyte glycoprotein, 4% being systemic, infectious, and autoimmune, sarcoid, as some audience members had mentioned, and lastly, drug-related, etc. And so optic neuritis as a whole is more common in North America and Europe rather than in Asia. Annual incidence varies, but estimates would be about 1 to 5 per 100,000. It can occur at any age, typically 20 to 50 years of age, and females have a higher predilection than males. I put an asterisk because this doesn't necessarily hold true for MOG. As we know, there's really no major gender predilection, but for the most part, typically females more affected. NMO, when we think of NMO, we think about having a lower prevalence in Caucasians and a higher prevalence in patients of Asian, African, or South American descent, and can be seen in patients over the age of 60, much like an MOG. Similar thing, less common in Caucasians, but more common in Asians, Hispanics, and African descent. So there's a very nice study that was conducted sort of globally. It was published in 2021, and it looked at aggregate data from 2008 to 2021. Of course, the caveats is this did use diagnostic coding. Some countries don't necessarily have access to testing. They're using different assays. So keeping that in mind, nonetheless, this is a fairly useful diagram to look at. And we can see with idiopathic and MS, it's the North American countries and Europe that we see this predominate as far as MS. So we certainly see this a lot in our part of the world. And when we look at here with NMO, as you can appreciate, we see in the Far East countries and South America is where it predominates. Now, it doesn't necessarily mean, of course, that it does occur in these other countries, but these are the most sort of predominant. MOG, similarly, you can see Far East is where it typically tends to predominate, but you can see in light blue, it is kind of scattered throughout, and we certainly do see MOG in the US as well. So how do these patients present? So, they have an acute onset of central vision loss. It really can be any pattern of field loss. And they have reduced color vision, which is often proportional to the visual acuity. And they'll have an RAPD. And astutely, as the audience members pointed out, unless there's a bilateral or previous optic neuropathy in the fellow eye, we may not necessarily see an RAPD. 90% of patients will have pain in or around the eye, and particularly with eye movements as the sheath is irritated. Visual acuity is mild reduction to no light perception, and 1/3 of patients with demyelinating optic neuritis may have mild optic disc edema. And so going forward, so this is a nice diagram. These are kind of the top three, if you will, things that we typically entertain when we're thinking about and autoimmune or demyelinating sort of optic neuritis. So you can see in the first panel, NMO, MS, and MOG, and you can see the gender predilection for females being more common in NMO and MS. The bilaterality, that's often a topic that's brought up that's more common in MOG, still definitely seen in NMO. Disc edema, that's the reason why we sort of entertain that in the differential of 85%. The visual acuity, of course, we know NMO often has a poor prognosis. As you can see, the numbers predominate for the acute and chronic visual acuity being somewhat poor. Longitudinally extensive, this can be seen in both, but when we think of the chiasm involvement, your mind, we should think of NMO, and when we think of more anterior involvement, we should think of MOG. And so going forward, so what does the imaging look like? You'll get the imaging, and so this is a nice schematic that shows an MS if you look at panel A here and then correlate down to B, you can see the anterior, this enhancement that you can see, short segment, which is characteristic of MS. MOG, you can see this longitudinally extensive. You can also see fat stranding as well, commonly. And NMO, notice how the chiasm is involved. So going further, this is a nice image that shows chiasmal involvement of a 70-year-old female who also had a transverse myelitis, as you may see as well. And the point of that is to think about that and ask some of those other questions of, you know, any weakness, numbness, bowel bladder, so on and so forth. It just can help you formulate your differential. Here's MOG, just a good example of that fat stranding that you might see. Of course, other things can cause fat stranding too, but MOG should come to mind for this. So what do we order? So, we would think of MRI brain in orbits with and without. You want to make sure you can specify at your center fat suppression, so you can really look at the optic nerve in its entirety. And you can consider spinal cord imaging. Of course, this will be in conjunction probably with your neurology colleagues for a complete demyelinating workup. The recommendation now is really to check MOG and aquaporin 4. We recommend the cell-based assay and really all new or first presentation suspicion for an optic neuritis. And like many of our panelists mentioned, you certainly can consider syphilis, ACE, ANA, chest x-ray, CT, so on and so forth, pending your clinical suspicion. And you actually don't need to necessarily do a lumbar puncture in a fair majority of cases, unless if you have kind of quote-unquote terms that have been supplanted, but atypical and typical, if you will, systemic signs, immunocompromised, severe optic disc edema, is it bilateral, are they rapidly losing vision, or if there's any diagnostic uncertainty, then certainly lumbar puncture would be appropriate to exclude other inflammatory or infectious causes. And going forward, so I'll use these terms typical and atypical. I know neuroliterature kind of renders this sort of obsolete, but I think it's still relevant to think about that. So when I say typical, I'm referring to MS or idiopathic, or what we see most commonly in the US, and then atypical being NMO, MOG, et cetera. So what we know is that for typical, following the optic neuritis treatment trial, IV solumedrol, they did 250 milligrams QID for 3 days. We often do 1 gram per day monitoring them, and followed by an oral prednisone taper. You could do a smoothie, quote unquote, 50 milligram tablets of 25 tablets per day, followed by for 3 to 5 days, followed by an oral taper. Now for NMO, you really want to do IV solumedrol for sort of the full 5 to 7 days. And these patients be primed, or think certainly about PLEX. Oftentimes it can be done concomitantly, which is plasma exchange therapy. And these patients inevitably will require some form of immunotherapy, eculizumab, inebilizumab, so on and so forth, as you can see. And do recognize that immunomodulatory therapy for MS should be avoided, as it can worsen NMO. In MOG, you don't necessarily need to start them on long-term immunotherapy. Often it can be 50% of the time can be monophasic. So how do they fare? So, they may worsen over 7 to 14 days, and then they will improve typically over 2 to 3 months. And oftentimes they can improve even up to 1 year. 90% of patients, as we know in the optic neuritis treatment trial, improved to at least 20 over 40 at 6 months. But they still may notice some residual symptoms, washed out colors, Utah phenomenon, Pulfric phenomenon, etc. The recurrence rate is about 35%, as we know. And of course, the question does come up, will I develop MS, so on and so forth. So a lot of this is determined by the presence of lesions. In atypical, again, this is NMO and MOG as I'm kind of clumping together. Some patients can develop this entity of CRION, as you may have heard or read about, where they kind of are steroid dependent and steroid sensitive. They get better and you taper and they get worse. And that's often, or can be seen, associated with MOG. Prognosis for NMO is often poor, and MOG often has a better or good recovery, rather. And of course, we do have to think about that other 4% that we talked about with, I know Dr. Perez will talk in a little more detail, but certainly various viral agents are known to cause optic nerve, optic disc edema, painful vision loss. So like the audience, discussed syphilis, Lyme, Bartonella, TB, meningitis, post-vaccine, sarcoid, and then we're learning more that GFAP and CRMP5. Of course, these also have other things, vitritis, so on and so forth, but relevant to think about. And with that, I'd like to, of course, thank my co-presenters, Dr. Golnik, and all of you folks for listening in.
All right. Well, thanks very much, Jay. Very nice comprehensive review of optic neuritis, which is becoming an increasingly difficult entity to try to characterize with all these new discoveries. I would just say one thing about the MRI and the enhancement, and that is, although most people with optic neuritis have enhancement there, you do not have to have enhancement to have optic neuritis. I've had plenty of patients where the radiologist says, no enhancement, no optic neuritis. that is not, optic neuritis is a clinical diagnosis. If there's enhancement, that helps you. But if there's no enhancement, it doesn't mean it can't be optic neuritis. Mario, go ahead and start sharing your slides. So that's one. And then, of course, you showed that pie chart from Dr. Miller. That would, I assume, be the US experience, because there was 80+%, MS or idiopathic. If you did that same pie chart in China, it would be very different. NMO would be a big part of that chart, as you pointed out with some of those other slides. So very good. Okay, so Mario, go ahead. He's going to finish the short talks on infectious optic neuropathies.
Okay, let's start with the question for the audience. The proper clinical diagnosis of infectious optic neuropathies is based on A, epidemiological data, B, clinical history of the patient, C, systemic symptoms and signs, or D, pattern of ocular involvement, and E, all of both. Correct. All of them are important when we are thinking about infectious optic neuropathy in a patient. Okay, infectious optic neuropathy typically cause atypical optic neuritis in the patients. They have different forms of optic neuropathy. The severity of the visual impairment can vary, and there's no pathognomonic clinical presentation of an infectious optic neuropathy. The proper clinical diagnosis is based on epidemiological data. It depends on where you practice. It depends on what is common in the region where you are. For example, during Colombia, if I'm thinking of an infectious optic neuropathy, I want to rule out syphilis, TB, toxoplasma. It depends on the clinical history of the patient. If the patient has, for example, HIV, if the HIV infection is well controlled or not, because if it is not well controlled, you must rule out less typical microorganisms. It depends on the systemic symptoms and signs. Those systemic symptoms and signs can help you to guide yourself into the diagnosis to rule out what is common in your area. And it depends on the pattern of ocular involvement. Resultant ischemia, edema, and inflammation may coexist with the inflammation of the optic nerve. The clinician must maintain a high index suspicion on, depending on where you are, as I mentioned before. It is partnered with colleagues providing pulmonary, otolaryngology, and infectious disease expertise to facilitate your diagnosis. We have to learn how to collaborate with other colleagues. So, if you are suspecting an infectious optic neuropathy, you have to ask your patient if about the travel history, recent travel history, because it may vary. Your diagnosis may get a little bit more ample if the patient has gone to certain areas with endemic diseases. Please ask the patient for systemic involvement, if other symptoms like fever, skin rash, look for neurological involvement, and always ask for the immune status of that patient. Look for HIV, concomitant HIV infection, and always rule out HIV. There is not a pathognomic pattern of nerve involvement in any optic neuropathy, so you cannot guide a diagnosis depending on the compromise of the optic nerve, but always look for additional ophthalmological findings like retinitis, choroiditis, vitreous inflammation that can guide you to an infectious disease. Look always for periocular inflammation, especially in immunocompromised patients, because they can guide you to life-threatening infections like mucormycosis. What to look for in the patients? It will depend on what are you suspecting and what is more common in your area. You can ask for CBC, set rate, serological testing, blood cultures, PCR, antibody assessment in acute tumor, vitreous, serum, or CSF, tuberculosis skin test, or quantiferon, or CT, or an MRI. It depends on what you're suspecting in your patient. Let's see two cases. For example, this is a 20-year-old male that had sudden profound visual loss in the right eye without ocular pain 1 month prior to consultation. There was no relevant past medical history. He has best visual acuity of curved finger on his right eye and 20/20 on his left eye. He has a right RAPD, and there's the Ishihara was abnormal in the right eye. This is the appearance of his fundus. He has optic disc edema, as you can see, in the right eye, and a normal fundus on the left eye. He has a central scotoma on the right eye. And as you can see on the OCT, he has inflammation of the edema of the nerve fiber layer. And he has a decrease in the ganglion cell layer in the right eye. But when we check for the macular OCT, we can see this thickened granular RPE that we cannot see in the contralateral eye. And these are the lesions when we check the ellipsoid layer in the macular OCT. So we have optic disc edema with these lesions in the RPE consistent with posterior placoid chorioretinitis and a mild, you can see, a mild vitreitis. So we have vitreitis with posterior placoid chorioretinopathy, chorioretinitis, and this edema. You have to think about syphilis. We test this patient for syphilis, and it was positive. He has a RPE reactive in 64 dilutions and a positive FDA-ABS. So this patient was treated for ocular syphilis. A second example is this 23-year-old female with rapidly progressive visual loss in the right eye with pain with eye movement in that eye. On the MRI, we can see this hyperintense perineural hyperintensity in T2 consistent with perineuritis. When you check the fundus, she has this chorioretinal lesion, floppy lesion, very close to the optic nerve, and he has positivity of IgG for toxoplasma. As we are in Colombia, this is very, very common. It's a very common cause of optic neuritis. And so always guide yourself by epidemiology in your region and your clinical suspicion when you are thinking about optic infectious neuritis. Thank you.
Okay, well, very good, Mario. Thank you so much. Okay, so we've heard about the three sort of either entities or categories of entities that would be the most likely things. We mentioned earlier some very unusual things. This was really meant to try to get you thinking about the most common stuff that you're going to see. Most of those other things probably going to be diagnosed by a neuro-ophthalmologist if you have one. So this is a polling question for the audience about our case. So what do you think the diagnosis is for this case? After hearing all those talks, after the discussion and questions and answers, do you think it's optic neuritis? Do you think it's NA-AION, or do you think it's infectious optic neuropathy? All right, so interesting. So the majority of people think it's NA-AION, and then kind of evenly split between optic neuritis. And I think that's part of the point, is that sometimes it's hard to know. We said earlier that the MRI was normal, no enhancement. Well, maybe that means it's NA-AION and not infectious or optic neuritis, but you can have infectious and without enhancement. We talked about NA-AION, well, she's got risk factors. I would say that certainly you can clearly a fair percentage of people get NA-AION under the age of 50. So now that said, probably not age 20. That would be pretty unusual. But you know, in the mid 30s to 40s, certainly that's common. I don't want people to go away thinking that NA-AION is uncommon over 50. It's certainly still common over 50. It's just that you got to then also think about giant cell arteritis. And depending on where you live in the world, giant cell arteritis may be more or less common. And then infectious optic neuropathy. Well, she had no other symptoms or signs of a systemic infection. So let me just move on. So here's our patient. And this, again, this fundus photograph is from 2 days after her symptoms. She had a big evaluation. It included pretty much everything the the participants mentioned in that. So a number of blood tests were sent at that time. Ultimately, a blood test did become positive. I won't say what it was, but I can tell you when she came back in a few days, she looked like this. Now, and so what I'd like to do, if possible, for the host, and I don't know if it's possible because we didn't discuss this in advance, is it possible to show that same question that I just asked the audience again? There you go. So does that change your tune? Do you think that, what do you think of the diagnosis is now based on this 6-day follow-up visit that you're having with the patient? Does that change your thought about what the diagnosis is? And remember, the other thing is that although there is a disc at risk in the other eye, that is important because if there wasn't, you'd say it can't be NA-AION. But it doesn't mean it is NA-AION just because they have a disc at risk. Aha, okay, so we've changed a fair number of people's minds, appropriately so. So this, as one of the participants pointed out early on before they saw this, and as Jay pointed out in his talk, sometimes, and you can kind of see if you look here, maybe if you can imagine, there's a little elevation, there's a little fluid in the retina. It's too soon for that exudate to coalesce into this nice star of what we call neuroretinitis. So early on, you may not see the star. An OCT will show you all this fluid. Now, potentially anything that causes huge disc swelling could cause a star, potentially. But it's rare. I mean, I don't think I've ever seen a complete star in NA-AION, but I mean, there are reports. So it doesn't mean if there's exudate in the macula, it can't be something else. But certainly if you see it, you've got to be thinking infectious. Infectious, infectious, infectious. And in the United States, we are thinking syphilis, but we're thinking cat scratch. And the point is that although she had a cat, and in fact, if you want to be even more specific, a kitten, because it's more common with getting scratched by a kitten, but people don't always remember that they got scratched or not. I mean, you got a cat, it's there every day. She said, no, I don't really remember. And in fact, you don't actually have to be scratched by a cat because it can be spread by a flea on a cat. So if your cat has a flea and the flea bites you, you can get Bartonella henselae. Now, I know this is not common necessarily in all parts of the world, but the point is you should be thinking infectious if you see this, but you may not see it early on if you see this patient within a day or two. So let me just, I'm gonna, I think, not have any more. I want to just summary. Okay, so I think the points that I'd make, and then we're going to open up to questions, and then we'll see if there are questions. So if you have questions, I know there are some in the chat or in the question and answer right now. We'll get to those in a second. Let me see if there's anything else I wanted to say. I think that in general, when we see unilateral optic disc swelling, we talked about the 3 most common sort of scenarios and then the subgroups. And as Mario said, infectious depends on where you live, right? I never see a lot of those entities that were on his flowchart list of things. So depending on where you live, things are going to be common. If you live in India, tuberculosis is going to be a lot more common than in the United States. So I think that's the main point with infectious things. Of course, if there are other signs, fever, systemic symptoms of infection, that's relevant. For NA-AION, all the points that Funmi made about, check the other disc. Is there a disc at risk? If there is, that doesn't mean it's NA-AION, but if it's not a disc at risk, think again, think long and hard, because the most important risk factor is that crowded, congested disc. As far as optic neuritis goes these days, really our management of optic neuritis has changed over the last decade or so because we have a blood test for NMO. We have a blood test for MOG. We didn't have that before, and now we do, and that's changing how we manage these patients, as Jay said. And if someone's presenting with their first episode of optic neuritis, you don't know what they have. What kind of, and even if you're sure it's optic neuritis, they have pain on eye movement. And this patient didn't have pain on eye movement, even though they had an infectious optic nerve problem. Not everybody has pain, 92% in the optic neuritis treatment trial, but that means 8% didn't. And 8% of a really common thing still is, you're going to see it. I think that's sort of what I have to say about the summaries. Let's go to the, do any of the panelists have any other thing that I left out they want to say, or Jay, go ahead.
Yeah, I did want to mention, of course, excellent point. I completely agree with Dr. Golnik that, you don't have to have contrast enhancement. You can still have an optic neuritis. And in addition to that, you may see sometimes optic nerves will have T2 signal. That might be reported on the radiology report. A T2 signal, hyperintensity seen on optic nerve correlates for optic neuritis. It's just a caveat, just important to recall that, T2 signal is nonspecific. It can be seen in any of these types of optic neuropathies, even normal patients, glaucomatous, etc. So just kind of keep that in mind when you're interpreting or looking at the MRI report. That T2 signal doesn't always necessarily mean this optic neuritis.
And Jay, in your, I can't remember in your talk, did you mention the perineuritis, the perineural enhancement?
Yeah, and in one
Okay.
the fat straining, the perineuritis, yes. Yeah.
Yeah, in other words, in MOG, you often can, a third of the time, you can see the perineural enhancement. So enhancement of the optic nerve sheath, which you tend to not see in other entities. You might see it infectious, but in other types of optic neuritis. So, all right, I'm going to go to the questions and I'm try to sort these out. So there's a question about lupus neuritis. Could this not also have palish unilateral swelling? I guess interestingly enough, in 35 years, I've never seen a case of lupus optic neuritis. So I think it's got to be pretty darn rare to be lupus. I've seen a lot of patients who were misdiagnosed as having lupus, but I don't think I've ever seen lupus optic neuritis. And so I'm not sure about that answer. Does anyone have experience on the panel with lupus optic neuritis? That's how rare it is.
That's rare.
Yeah, okay. Funmi, there's a question that says, when you say vertical cup to disc ratio, are you saying that the contralateral eye is higher cup to disc ratio, being vertical higher than in horizontal?
No. When I'm talking about vertical cup to disc ratio, it's possible to measure the cup to disc ratio vertically as well as horizontally. Generally, in ophthalmology, it's the vertical cup to disc ratio that we tend to align with, because the superior and inferior nerve fiber layers of the rim are thickest in that region. So if you start noticing any increase in that diameter, that means you are losing that nerve fiber layer. And so that's what makes that more important. But the disc at risk is generally a cup to disc ratio, vertical cup to disc ratio less than 0.3. So in this patient, for instance, it was 0.1, but as we can see, this patient generally hid her diagnosis to the last possible minute.
Yeah, sorry, I did that.
That was a nice case. Very exciting.
Then there's a question about, is the altitudinal field defect, I assume we're talking about NA-AION, is the altitudinal field defect more common superior or inferior?
A patient can choose to have, more swelling of either the superior or inferior as they please. But in the books, I tend to see that people talk about more superior nerve swelling. So inferior altitudinal defects you may expect maybe more.
I think I certainly see more commonly inferior, but you can't, I mean, you can't rule out NA-AION with a superior defect. So, but I think in my experience, at least, inferior is more common than superior. There's a question about statins, the use of statins in NA-AION.
NA-AION, you see, if patients have hyperlipidemia, which can cause an anterior ischemic optic neuropathy, then they may be placed on statins to treat it. But I haven't seen any of the literature talking about statins being a cause of NA-AION.
Or using statins. I don't think there's any evidence base to recommend statins in the use of NA-AION. It is a compartment syndrome.
Needed.
Yeah.
For
I'm not sure about this. It says Dr. Fumi mentioned briefly about RAPD in causing superior and then inferior field defect. I missed that part. What was the reasoning?
No, what I was saying about an RAPD is that it is a sign of optic nerve dysfunction. You know, when there's a differential activity of the optic nerve between the two eyes, then you expect to see a relative afferent pupillary defect. So there's an afferent pupillary defect relative to the functioning of the other eye. And that is not to say that you cannot have, depressed function of both eyes, in which case you will not see a relative afferent pupillary defect, but you will know that there's afferent pupillary defect because the pupils will be sluggish in both eyes. The only thing I mentioned about visual fields after the RAPD was that it is a possible sign of the ischemic optic neuropathy. So I mentioned that you look out for poor vision, look out for poor color vision, look out for an RAPD, look out for that pale swollen disc. And then when you do the fields, you might be able to identify a field defect, which could be anything, but more commonly is described as an altitudinal field defect, especially if there's differential swelling of that disc and the swelling is more superiorly.
Yeah. Okay. Jay, you talked a little bit about RAPD and unilateral optic neuropathy. I think there's some confusion. The question is, can we have no RAPD and unilateral optic neuropathy, and what is the mechanism?
Yeah, definitely. So, when you see an RAPD, you can certainly, just like Dr. Ogun had mentioned, that would imply either a unilateral optic neuropathy or an asymmetric optic neuropathy, right? These patients can also have bilateral involvement, in which case you wouldn't see an RAPD. So that's kind of the idea. It doesn't necessarily differentiate the etiology, but it's more looking at the pupillary responses and recognizing, could there be a bilateral process? So, giving more credence or more value towards looking at also the contralateral fellow eye.
I think the point is that if there's a normal optic nerve on one side and there's an optic neuropathy on the other side, there should be a relative afferent pupillary defect. Now, if it's a really mild optic neuropathy, it may be a really small relative afferent pupillary defect, but there should be, if the other eye the nerve is normal. So there is no mechanism that there would not be. How do you this is for Mario. How do you differentiate this from this diagnosis from toxo at early stage? I assume he's meaning Bartonella, I guess. Yeah.
Yeah, I think it is not possible to differentiate them in an early stage, like a very high confidence, but Bartonella lesions are related only with mild, if not vitreous inflammation, local vitreous inflammation. So these chorioretinal lesions are not associated with a high index of vitreitis. On the other hand, toxoplasmosis causes a very, very high inflammatory local inflammatory reaction in the vitreous. So that kind of differentiation in the inflammatory status of the vitreous can guide you or can help you to differentiate between Bartonella and toxoplasma.
Good, yeah, and of course blood testing ultimately, but in clinic,
Yeah. In clinic, yeah.
Let's see. Is the absence of RAPD possible with NA-AION or optic neuritis only if they have contralateral symmetric optic nerve damage? Otherwise, you should see a relative afferent pupillary defect. The star on the fundus imaging after 8 days, was that avoidable? No. That star was the exudate, we think, the exudate, the fluid was all there, but that star is when exudate coalesces in the nerve fiber layer of Henle, which gives you that star appearance. So the thought is that that fluid is kind of starting to resorb, the fluid part, and the exudate is then more evident in clumps. I guess that's how I look at it. Now, I don't know if there's proof of that, but it's not, as best we know, it's not preventable. What does the stars seem? So by definition, if you see a swollen nerve and there's a star of exudate, we call that neuroretinitis. Neuroretinitis is not a diagnosis, just like optic disc swelling is not a diagnosis. The question is, why do you have neuroretinitis? Why do you have optic disc swelling? So neuroretinitis has a differential. In the United States, it's usually either post-viral or cat scratch, Bartonella henselae. But it can be seen, as we mentioned, in other infectious, and even in, you can see what looks like neuroretinitis in papilledema. If you have big time papilledema, disc swelling from increased intracranial pressure, you can spill fluid and exudate into the retina and end up what looks like neuroretinitis. And I saw a kid years ago who had sent to me bilateral neuroretinitis, and they had a venous sinus thrombosis and increased intracranial pressure and papilledema. Does anyone have any experience in trying oral prednisone for NA-AION, although studies showed no benefits? Well, I can tell you the meta-analyses have shown that steroids have no benefit. I have, for a while, I was offering people steroids, and this was probably 10 to 15 years ago, based on one study that was a bad study. And I said, well, there's some data that if you present with visual acuity worse than 20/60, that it might be of benefit. And it's all anecdotal, but I had nobody who had any significant improvement in vision really on the steroids. So I don't know. I in my talks on NA-AION, I basically say there is no proven treatment still, no evidence-based treatment for NA-AION. One patient, or someone asked, how did the patient respond to treatment? So Bartonella henselae, there are no really randomized controlled trials. And years ago, it's a funny story, which maybe I'll tell since there aren't really many other questions. My group actually were the first group to publish the cause of cat scratch disease. So back in the 1990s, sorry, I know many of you probably weren't born yet. In the 1990s, on our examinations, the American Board of Ophthalmology exam, in a patient with that picture, they asked what bacteria caused this, and the answer was Aphippia felis, which was a bacteria that occurred in cats, and they thought that was what it was. But then someone by the name of Diane Hensel, a microbiologist, discovered the bacteria that causes cat scratch, and back then they called it Rochelameia henselae. And they since have done away with the Rochelameia because they realize it's really part of the family of Bartonella. And they call it Bartonella henselae, after Diane Hensel. And back then, I had a couple patients with neuroretinitis, and I'd heard about this, and I called the CDC in the United States, and I said, hey, are you guys testing for this? And they said, oh, yeah. So I sent in the blood, and they sent me a letter back, and they said, yeah, it's positive. Hey, by the way, we have like 4 other patients from around the country that have been sent in with positive tests. Do you want the names of the doctors? And so we got together as the group of doctors, and we published the first paper on Rochelameia henselae. But back then, cat scratch disease was thought to be a self-limited condition. And so the infectious disease experts said, well, you don't have to treat them with anything. It goes away like a cold, it goes away on its own. But now we know the bacteria, and we know there are antibiotics that can kill the bacteria. And we also published a paper some years later about not everybody with cat scratch has good recovery of vision, although in general, people have good recovery, not everybody. So most people, if they know it's an infection and they know there's an antibiotic that can kill it, they want the antibiotic. So we do use antibiotics. There's different ones you can use, ciprofloxacin orally, although you can't use that in kids. They use isoniazid, I think, too. I'd have to Google it again to find out. She was treated with antibiotics. There's a question about, do you give some steroids at the same time? Because we know, like for syphilis, for instance, you can give steroids concurrently and the visual recovery can actually be better because you're getting rid of the bacteria with the antibiotic and you're getting rid of the inflammation, which can cause damage with the steroids. So she did well. Do we include toxo, IgG, IgM as part of a workup aside from Bartonella for neuroretinitis? Mario, I guess you would in your world.
Yeah, we do actually, because toxoplasmosis is very common in Colombia and Brazil. So we always check for toxoplasmosis in our patients in neuroretinitis.
I think it depends again. You're going to look.
It depends on where you.
Yeah, you're going to look for the common infectious.
It will depend on where you practice.
Okay. All right. Well, we're just about out of time. Well, one last question. How about steroids for prevention of full NA-AION when you incidentally find distal in your regular control visit in a patient with, there's absolutely no evidence base to answer your question. And thus I would not. But there is no evidence for steroid use in any form of NA-AION. All right, well, listen, we are at the end of our allotted time. I'd really like to thank my panelists, Drs. Patel, Perez, and Ogun, for their excellent comments and talks. I hope everyone learned something, and we'll see you somewhere around the world at some meeting I'm at. Say hello, please. I love it when people come up and say, oh, I saw your webinars on Orbis or your course. Please say hello. I love that. And otherwise, everyone else have a good rest of your day. In my world, it's 7:30 a.m. So I'm not wherever you are, have a good rest of the day. And thanks everybody for participating.
Thank you.
Okay.
Bye-bye.